Hey, welcome to the Clinical Cousins YouTube channel. My name's Matt, and this video is going to be on monoclonal antibodies. So we're hearing a lot on the news lately about monoclonal antibodies with drugs like Regen-Cov and BAM. I don't want to try to pronounce that word. And especially over the last decade, even with drugs for Crohn's disease, cancer, leukemias, MS, non-Hodgkin's lymphoma, and other diseases where it seems the body has sort of went awry on its host. So in order to understand monoclonal antibodies and better communicate with our patients and us have a better understanding of what monoclonal antibodies is, we have to have a little understanding about how the immune system works, and especially B cells. So we're going to go into a little dive into the immune system. We're not going to take a deep dive there, but just enough to understand the process of monoclonal antibodies and how we produce antibodies. So antibodies are produced by B cells. So what are B cells? B cells are produced in our bone marrow. These cells, about roughly 10% of them, make it out of the bone marrow, and they're created with a specific purpose. These B cells are created to find a single specific sequence of proteins, or an antigen as we call it, which could be a bacteria, a virus, and we hope not our own body, which is where we get a lot of autoimmune diseases. So this B cell is made, and it's made to recognize a certain sequence of proteins. So unlike I used to think that your body would have a virus come in it, or a bacteria, and when that virus or bacteria was introduced in your body would say, hey, this doesn't look right. It would start fighting it, and then it would develop a response to fight that bacteria off. The truth is your body already has the cure for the flu, the cold, SARS-2, COVID, and it's made by these B cells that have already been produced. But these B cells are only produced to recognize a single sequence of proteins that's abnormal. So if your body never sees SARS-2 COVID, or your body never sees a common cold or some weird disease out in Africa, it will never build an antibody. It'll never make a huge antibody response to that, and it'll live a very solitary and lonely life. But what happens is, if this B cell happens to come across an antigen or a foreign invader that it recognizes, it goes, hey, this is a sequence of protein that I was born to recognize. The minute it comes into contact with that, it starts a process called differentiation. So it's activated and it starts to differentiate. So the B cell then determines what direction it wants to go in its life. Does the B cell want to become a plasma cell, or does the B cell want to become a memory B cell? So in this process, it will either become one or two things. The plasma cell is made to just pump out antibodies. It pumps these things out, or what we also call immunoglobulins. So it's just going to pump those out and pump those out. These plasma cells are antibody producing factories, and they pump those out as fast and as quick as they can. Now, they may decide to go the route of a memory B cell. A memory B cell is a cell that says, you know what, I'm going to hang around. We ran into this guy one time, and he might come back for a second fight. So if he does, I'm going to hang around so we can mount a quicker response to this guy and be able to fight him and overtake him quicker. Because for these B cells to undergo this process of differentiation and activation, this can take up to 14 days or more to develop a robust enough amount of antibodies to be able to combat these viruses or bacteria we come in contact with, which we know in COVID, it's usually days 5 through 10 where people start to really have a lot of difficulties. So at that point in the battle, there's not a sufficient amount of these to help them win. So that's why we've came up with a lot of these antibody therapies, which work good early and not late, because the damage is already done. That's why those first 10 days are crucial when you're going to get antibody therapy, to get them in. And especially the first 5 to 7 days is really from symptom onsets when you want to get monoclonal antibody therapy. So what is an antibody? So this is producing antibodies, but what are antibodies? Well, antibodies are a recognition site for foreign invaders, like I said, we hope, of viruses and bacteria. They have two long proteins here and two short proteins here on the end. Now, it forms what looks like a Y. We call this bottom section the FC portion. It looks the same in all of them. That way your body knows, hey, this is mine. So that's why this FC portion is sort of the same, and it's stuck to this cell. It'll also, when it sticks out, when the Y comes in contact with the antigen and forms what we call an antigen-antibody complex. This end will stick out and it will be stuck sort of on the virus like this, and the FC portion will be out, so the other parts of your immune system can recognize, hey, this is mine and it's come in contact with an invader. I need to help kill it. So this portion up here is what we call our variable portion on our antibody. And that's where the specific, where it has to specifically fit, just like a key in a lock in a door, has to specifically fit in this antigen binding portion that was already prefabricated and made by our body. So when that little blue circle, as I drew it, fits into that little blue circular spot, it becomes an antigen antibody complex. At this point, the antibody is in use. So what's the point in it binding up there and permanently binding to this antigen? Well, the point of it is it can attach to the receptors on a virus or on a cancer cell or on a bacteria. And when it sticks to those receptor sites, now let's say it's that S-spike protein, which is what the vaccines made for with COVID. When you make these antibodies that stick there, now that site can no longer enter through those ACE2 sites in our body. It sort of binds and neutralizes them where they're sort of useless. Or it may bind to a bunch of receptor sites on a bacteria so it can't take food in and it starves itself to death. But specifically when it binds to that S protein, what it does is it keeps it from entering ACE2 sites in our bodies with COVID-19. And the place it likes to enter is through our nasal neuroepithelial cells, which is why we lose our taste and smell, because we have ACE2 sites there. In our lungs, which is why we end up with that dry, hacky cough, get short of breath, and have the pulmonary complications with it. And it also likes to bind to the ACE2 sites in our intestines, which is why we get diarrhea. And that's why we specifically asked, do you have a headache? Have you lost taste or smell? Are you having a cough? Have you had recent diarrhea? We ask that because that's the way this gets in. But if this antigen antibody complex can bind to it, it won't let it enter in through those sites. If it can't enter in through those sites, then we don't get those complications that come along with that. So that's one way these antibodies work. Another way, they can attach to the pathogen. They can sort of just surround it, make it clump up, make it slow, make it useless. We call this agglutination. It can assist in opsonization. What's opsonization? That's where we have those things, macrophages, that are like little Pac-Mans in our immune system that go around eating cells. Well, viruses and some of these diseases are really slippery. They're sneaky. They're like ninjas. They like to get in and do their job, and they're sort of stealthy and undetectable. But when this antibody sticks to it, it makes it stick out. Then your body goes, hey, this isn't supposed to be here. And when this FC portion binds with that macrophage, it can't get away. Now it's stuck, so it allows it to opsonization to occur. So another thing it can do is it causes antibody-dependent cell-mediated cytotoxicity. And this is just, it binds to the virus, binds to the bacteria, and then allows T cells and other ones to recognize it and kill those viruses or bacteria. It can attach to toxins. We have snake bites. We have antibody therapy, immunoglobulin therapies for a lot of toxins. It'll bind to the toxin, bind to their sites, and then make them where they can't affect the body, where they can no longer harm you. It also helps with the complement system of eliminating proteins, bacteria, viruses that it detects. So monoclonal antibodies are simply one clone of an antibody, or a single one of these, that they're cloning over and over again to help people's body specifically target a certain antigen or protein sequence. Now, that protein sequence could be that S-spike or protein sequence on SARS-CoV. It could be your body's own CD20 site for B-cell cancers, or HERS2 site in breast cancer, or CD52 with MS and leukemia, or tumor necrosis factor alpha with inflammatory diseases like Crohn's. These antibodies are targeted to one single antigen, and when it recognizes it, it'll attack that. So how do they make these for the human body? Do we extract them from other people who've had COVID? Well, we did initially get the first one for BAM and Regen-Cov from someone with this drug that originally had the original COVID virus. So we got the antibody from them, somebody who hadn't been vaccinated, had developed an immune response, and then they used a process of introducing that antigen or antibody into a mouse spleen, producing antibody, producing mouse spleen cells. They merge those cells sometimes in some of these MABs they make with myeloma cells. It forms what's called a hybridoma. They use a cancer cell that proliferates without stopping to use it to just pump out a bunch of B cells and antibodies so that we can make antibodies to inject either through IV injection, or now we do subcutaneous injections of some of these medicines to give your body antibodies to things to help you fight them off that maybe your body doesn't make, to help your body fight off processes where you have antibodies that are fighting your own body, or maybe your own immune system's went awry, so we want to sort of push that back and hold it back. Or in this case, where we want to make antibodies to fight a virus that your body's coming in contact with. So these are very targeted therapies. What's the difference? And these MAB drugs, they all usually end in MAB. If you see MAB, it's monoclonal antibodies. What are the difference in these drugs when the ones that we make to help fight Crohn's, ulcerative colitis, MS? A lot of these can give you serum sickness and a lot of other hypersensitivity reactions. And the problem with that is because these drugs are made to target your body's own immune system cells. So since you're targeting your own body, you can make your body make a response to it, and you can have a severe reaction. Now, we don't see this as much with the drugs that are made for COVID-19 because they're not targeting your body's own immune system cells. They're targeting a virus. I heard someone say, I wish we could make these for flu. Well, if it wasn't for the flu mutating nonstop, we probably could, but it mutates too much. So the good thing about the novel coronavirus and its lack of significant mutation is the fact that we can make monoclonal antibody therapy for it. So with these target a virus, so since they're not targeting your body, that's why usually we just look for that initial anaphylactic reaction people can have just sometimes to the things that we make these with. And if they do good for that first hour, we watch them, then we send them home. So these drugs, while the same, the side effect profile is quite a bit different, and that scared a lot of, I think, primary care providers, mid-levels, and people from wanting to recommend these because of they know about some of the side effects that occur with these, but they occur a lot less with the ones we make for COVID-19. So the other point I was going to say is just that the ban was for the original coronavirus, the novel coronavirus before the Delta variant, and that's why it was effective. But now we've switched to this one, and we may switch again if we have another variant. And it's not that these drugs don't work, it's that they've cloned this antibody from the original, and they've cloned this antibody from the Delta variant. So that's why it's more effective. With these drugs and antibody therapies, they're better, the earlier the better. You don't get these for viruses early on. They're useless later. It'd be like giving someone acetadote for a Tylenol toxicity after the Tylenol killed their liver out. They're going to deal with the effects of the liver being hurt. It doesn't reduce the damage it's caused. It prevents more damage. So you got to get these within the first 10 days. People that are older than 65, hypertension, diabetes, you can look up all the risk factors. Even people who've been vaccinated can get these, and they do prevent hospitalization. So hopefully this video has been helpful. If you would like to, you can like and subscribe to the YouTube channel, and we're going to have some more stuff up for CCRN review, and also to go over COVID, since it seems to be a popular topic lately that probably going to be around for a while.